It's a mess.
Yeah,
A lot.
but I was able to pick one that looks similar to what I had, because I thought we had con wood.
Pondwood?
Mhm,
That's right.
yeah,
Wow.
and we hadn't been able to find it to like take the carpet out,
Really quick.
continue, so I better love this that I'm getting.
Yeah. Hang in there.
Okay, all, are we ready to get started? I see everything, they're sitting down. Well, for those of you that don't know, well, at first I want to start by saying welcome. This crowd is awesome. Thank you everyone on Zoom and Facebook Live for joining us as well. I'll start by introducing myself. My name is Logan Banks. I'm president of the board of CSRA Parkinson Support Group. So really, we're so happy that everyone's out here. We have an amazing speaker tonight. And you get to ask him questions, which he opened himself for that one, so we're pretty happy about it. As far as announcements, it's a new year. You know, we're away from the pop walk, but it's always at the front of our mind. A lot of great things to come in 2023. So if you have any questions or if the board can help with anything at all, please let us know. We're here. Otherwise, I'm going to hand over the mic to Dr. Morgan to take the show.
Thanks, Logan. So I was gonna let it be an open mic tonight. Any kind of questions that you have about Parkinson's disease, non-Parkinson's disease, medicine, whatever you need to know. And normally I could do a presentation, but I think a lot of Q&A would be a good idea for folks to get some answers to questions that are burning that they may not have had a chance to get answers to. So, anyone want to start off with a question about Parkinson's? Yeah, Dick.
Yeah, so just a generic question about new treatments slash medications that are kind of out there available. Maybe some in the pipeline, if there are any in the pipeline that are interesting that you might know about, and about the vibrating glove.
Mm.
Could you restate the questions too?
Yeah. So Dick asked a question about new treatments or those that are in the pipeline for Parkinson's and the vibrating gloves. Do you have the ability to project a video and with sound?
Without sound.
Okay. Type in today's show,
Okay, I gotta hook up.
vibrating gloves.
1 second, I gotta hook up.
So did y'all see that piece on the Today Show?
No, but this is interesting.
Yeah, so I showed this the other day at our lunch and learn we had last week. We're starting back lunch and learns each month. It'll have sometimes it may be Alzheimer's, sometimes it'll be Parkinson's focused. I talked a good bit about Parkinson's this last week, some research things like that. But a group, I believe at Stanford, has come out with some vibrating gloves. Vibration to treat Parkinson's disease is not a new thing. A man named Charcot came out with that idea years ago. Anyone ever heard the name Charcot before? Okay. Charcot was a very famous neurologist, one of the fathers of neurology. He practiced at the hospital de Salpêtrière in Paris, France. There's a picture of him that's on the web, and essentially every major neurologist of the time did some training with Charcot. Tourette, have you heard of Tourette syndrome? Tourette trained under Charcot. Babinski, which is a sign of scratching your foot and your toe goes up to indicate a motor neuron lesion in your brain or spinal cord. He studied with Charcot. All of these very famous neurologists with names, syndromes, and things like that studied with Charcot. Charcot was the first person to diagnose MS and come up with the term multiple sclerosis. He also named Parkinson's disease after James Parkinson. Okay, because he knew about Parkinson's work from 1817 in England. Yeah, so Charcot had noted that when patients travel and they would ride in a buggy ride or a train ride, the vibrations tended to make them better after they had a vibrating trip that he thought. And then he made a vibrating chair. And the vibrating chair he used to treat Parkinson's disease. That wasn't so successful. It did make a big difference in patients' Parkinson's symptoms. This was also repeated by a group that you know up at Rush. Chris Getz and his group of very famous movement disorder neurologists also did a vibrating chair experiment and tried to see if it would help Parkinson's patients. They didn't find any obvious benefit. But a group at Stanford has come up with vibrating gloves. And in today's show video, if you pull that up.
We can't pull it up, but it's going to be posted on the Facebook page.
Okay, so look on today's show. There's a very handsome reporter with gray hair. I don't know why I noticed that. But he has gray hair. You'll see him in glasses, very studious looking fellow. And it shows his story about the vibrating gloves from a group at Stanford. So you wear these gloves, they go on both hands, and they stimulate your nerves, and apparently it can reduce tremor specifically for some period of time after that. There is some precedent for this in that there is a stimulating device called the Calitrio device. Calitrio device, what it does is it stimulates your nerves by wearing a wristband, and it can reduce essential tremor, like patients whenever they have tremor when they feed themselves or hold a drink or things like that. You can stimulate the nerves of the hand for a while, and then it reduces the tremor for an hour or two after you stop stimulating. So it's pretty interesting. A peripheral feedback process can change the central part of the brain and affect tremor. So that's pretty cool. But yeah, watch that on today's show. It shows an Indian man with a little common circumstance. A lot of these things, when they show them, there's only been 20 patients studied in this trial, but show you know, the best of all worlds. And he looks very off at one point where he can't move and he's freezing a lot. And his Parkinson's medications are worn out, it looks like, and then it shows him moving better. But he's also on with his levodopa that's kicked in, and he's moving better because of that problem. But they claim that it makes differences in brain structure and brain function, and may improve Parkinson's symptoms overall. So the gloves are very interesting. Got to be studied in a larger way. You get feedback, sorry. Got to be studied in a larger way to see how much they actually really work. Okay. Drugs for Parkinson's. What's the gold standard for treating Parkinson's disease? Everybody should know that. Carbidopa, levodopa. Okay. Why did they add carbidopa to levodopa? Nausea, so you don't puke. So originally, when a guy named Coetzee in 1967 showed that levodopa helped Parkinson's disease, he had to titrate it very, very slowly on patients from a low dose to a higher dose because it would cause such nausea and vomiting. Carbidopa inhibits the peripheral breakdown in your gut of levodopa so that you get more into your brain. So without carbidopa, you get a whopping 1% in your brain. With carbidopa, you get 5% into your brain, something like that. So it's not the most efficient drug. Why can't I just give you dopamine to replace what you've lost? That's right, it doesn't cross the blood-brain barrier. So that's why we have to give you levodopa. It's transported like an amino acid. Hence, if you are fluctuating with your on-off episodes and you have a lot of protein, which break down into amino acids, it can compete with levodopa for absorption from the gut. So making the best levodopa possible is a goal. There's transdermal patches that are hopefully going to be coming out. They're not coming out right now soon. There's an improved version of Rytari. Have you heard of Rytari, which is extended release carbidopa levodopa? There's an improved version of that is even longer lasting that's coming out. that will hopefully improve therapy. Right now, the half-life of levodopa immediate release that you take is 90 minutes. So in 90 minutes, half the drug that you took has been metabolized away. So that's why you take it more often. It's a short half-life drug. Ken Moby came out in the past year or two. Ken Moby is a sublingual preparation of a drug called apomorphine. It's not morphine. It's not a painkiller. It's a dopamine agonist like Mirapex or Whip or Nupro patch, just kind of that ballpark. And it's a powerful drug that can rescue you and turn you on and you turn off by being absorbed under the tongue, not having to swallow it. There's also Inbrija, an inhaled form of levodopa. Has anyone used Inbrija or Kinmobi before? Okay, not a lot of use of that. Inbrija is an inhaled form of levodopa, about 50 milligrams. Those from the 60s and 70s seem to be better at hitting this ball like peace pipe thing. That's a joke. Compared to the older generation, but yeah, so that's available now for a rescue to turn you on and help you. Yes, sir.
Is there any advantage or disadvantage? Solving the current digital
Is there any advantage or disadvantage to dissolving it in your mouth and not swallowing it whole? Yeah, so for regular Cinemat carbidopa levodopa, there's maybe some advantage that's kind of more broken up a little bit, that kind of thing, that you make it a little faster, but it still has to be absorbed in the small intestine in your gut before it works. Yeah. Yes, Joe.
We heard a lot about symptoms, like it's even though the gloves and everything else. The good thing that it's not a solution if they were.
Yeah, so that's a great question. We've got drugs that treat the symptoms that you're getting at, Joe, but do we have anything that's coming out down the pipe that hopefully will modify disease, right? What condition just had a drug come out that modifies disease for the first time? Alzheimer's, right? So Alzheimer's came out with a drug that was an infusion of an antibody that attacks the plaque entangles of Alzheimer's disease and eliminates that, and appears in the short term, 18 months to slow it down. We don't have that holy grail in Parkinson's yet, but we've been studying at MCG a drug from Neuralink, Neurally, Neuralink, and exenatide. Have you heard of Byetta before, diabetes drug? Anyone ever heard of Byetta? It's an injection, and it's a complicated mechanism, but it appears to work through neuroinflammation in the brain, reducing inflammation inside the brain. And there's promise that it may actually slow down Parkinson's disease. They're completing the initial part of the study, and hopefully we'll have the data the next few months or so of the top line results of that. So that exenatide drug was shown in England to actually, in a small study of 40 patients that received drug and 40 patients that got sugar pill, essentially, or injection. Those that took the drug had a slower disease progression over time compared to those that didn't. The other drug that we're looking at right now, and I'll mention two more, buntanetap. We're not doing the study for it. We couldn't work out the negotiations with the details of the project. But buntanetap is a new drug from Novus Pharmaceuticals. And what is the main protein that goes awry in Parkinson's disease inside the brain? You know? Yes, sir. Alpha-synuclein. That's the main component of Lewy bodies. Okay. You heard of Lewy bodies? Lewy bodies are made predominantly of alpha-synuclein, a protein that we all have in our body. But this one forms let's say this is normal conformation on this side, and this is the abnormal conformation. One abnormal conformation protein attaches to another one and then twists it to another abnormal conformation. And then it clumps up more and more. Okay. It's called an amyloidogenic protein. Lots of proteins in our body do that.
tau does that, which is inside the nerve cells of the brain. Alpha-synuclein does it. Beta amyloid, which is the plaque protein of Alzheimer's, does it. But these small molecule inhibitors like butantan, it actually can prevent clumping of tau, alpha-synuclein, and beta amyloid, all three. So it may be useful in Alzheimer's, Parkinson's. A dirty drug that does a lot of different, prevents a lot of clumping would probably be a better drug than a single mechanism. And they have cocktails that people take one day that attack things from a multi-pronged approach. The other one is UCB 0599, I think. The UCB study. UCB makes the most popular antiepileptic called Keppra. You may have heard of Keppra before, or levetiracetam. But UCB is studying this small molecule inhibitor to reduce clumping of alpha-synuclein. And again, it may slow down disease in early patients. That's what we're looking at. So, yeah, there's progress being made at trying to prevent the process from happening, prevent bad alpha-synuclein from spreading from neuron to neuron, which happens in the brain, and protecting those neurons that are left. Yes, sir.
I understand we had a researcher here some months ago, he was explaining there are two things he said Parkinson. The alpha-synuclein and suspension I were dead. And they have research into both of those. And I've asked him this, and I'll ask you the same thing. Do we know what the relationship is? One causes the other, or are they independent events? How do they work?
So alpha-synuclein is related. Thank you. Alpha-synuclein is related to the process. We know that. Okay. If you can't eliminate the gene completely because it's detrimental to life, so you need to have it. It appears to help out with synapse formation of having neurons talk to each other. It appears to be important in dopamine transport and formation at the synapse and things like that. So it's a vital protein, but for some reason, the oxidative stress environment of a dopamine neuron inside the substantia nigra, the black substance of the brain, it predisposes to lots of oxidative damage and problems that develop, and alpha-synuclein tends to be the protein that screws up and then starts forming clumps.
Do we know if does one cause the other, or the substantia nigra messing up cause the alpha-synuclein problem, or does the alpha-synuclein problem cause the other?
You can't separate them because alpha-synuclein is within neurons within the substantia nigra, so they're together there as part of each other. Yeah, Joe.
Non-motor specifically here. I can get people to take the test.
What three non-motor symptoms appear well before you develop Parkinson's disease?
Constipation,
Constipation,
decreased smell and taste.
decreased sense of smell, and REM behavior disorder. How many of you had those before you developed tremor or slowness? A lot of hands go up. So there was a study that we did, I'm blanking on the name of it, that looked at relatives of Parkinson's patients. That increases your risk a little bit, but it's not huge. And what we found was that if you had loss of sense of smell, and you had constipation, and you had REM behavior disorder. REM behavior disorder is where you fight and scream in your dreams, and sock your bed partner, fall out of the bed and stuff. Those kind of things. If you have those three constellations together, it's something like 75 or 80% chance you're going to develop Parkinson's disease. Okay, that's very predictive of going on to Parkinson's. So they're doing studies like that, looking at REM behavior disorder earlier, because you've already lost, by the time you present to the movement clinic, when you have resting tremor, you've lost half of your dopamine neurons. Half, because your body's been buffering that process and can handle it. Okay. And so we're trying to save it as soon as we can. But probably in sleep clinics where people have REM behavior disorder complaints, or if there's a constipation clinic, but believe me, constipation's a dime a dozen, right? Who doesn't get backed up every now and then? So, it's not so specific, but having all three of those together is pretty specific and helpful. Yeah,
I've heard of some different research projects that inhalants seem to be a sort of a shortcut to the brain, past the blood-brain barrier. Is that not the case?
yeah, so like Inbrija goes through the lungs. It goes through the lungs to get to the brain, to the circulation. Kenmobi goes through the tongue vasculature to go to the, and skips the primary metabolism past through the liver. So they're trying to work through that. Crossing the blood-brain barrier is easier in Parkinson's and Alzheimer's because it's leaky. The blood-brain barrier is leaky in those conditions, and so you can probably get stuff in easier. And also, you may have heard of nanoparticles before. Nanoparticles, and probably can attach stuff to them and probably cross the blood-brain barrier is easier with that too. Yeah. So that's whenever you're looking at a drug to try to slow anything down, you want to see that it's blood-brain barrier penetrant. Yes. Yeah.
When do you decide and use it?
When do I what?
And how do you decide to?
In Breja. Well, the drug rep came by and brought lunch the other day. And I apologized to her. I said, I know I don't use hardly any of your drugs. So I don't use much of that drug. It's just, you get in a habit. I did the clinical trials with Kenmobi. And so I was used to handling that strip, and I prescribed more of that for rescue therapy. But it's a good drug and it helps people that are, so the classic use would be, let's say you're riding a roller coaster with your levodopa during the day, up and down, right? And the right time to take it is right as you're starting to go down on your levodopa, and when your on is turning into an off, right when it's starting. That's the best time to use the Breja or the rescue medications, the Kenmobi. I don't use it enough. I've probably read it 4 or 5 times. I have had patients, one patient with very advanced Parkinson's disease who has a very bad off. He feels terrible. He gets red. He huffs and puffs. He can't move. It's not only just a physical off, it's a mental off too, a non-motor off. And I would treat him with Inbrija at the bottom of his off. It didn't cut it. Yeah, so it's only 50 milligrams. It's like half a Cinemat pill is what it's equal to a levodopa amount. So it's not quite as strong enough to rescue you from a full off, in my opinion. Yeah.
As I shared with you earlier, my husband's a veteran, so we get all of ours through the VA. Does the VA have any of these drugs? My husband just started with, how to day one fitness.
Great.
And I noticed that about 30 minutes into his workout, his tremors are back and excessive. But when we're at home and he's sitting around, they're not as aggressive. Is there something that we can do to, in fact, somebody said when your wife needs to adjust when you take your med before it comes, we typically takes it at 7, we go at 9, and we're only there an hour, but.
So took it at 7 and you go at 9. Does he feel like he's worn off between 7 and 9? That it's already worn out on him, or does he still feel like it's working?
He doesn't really know, sir.
Yeah.
I see it.
Some folks don't know on and off very well when they're in the middle of it. Some folks do. But it will become more obvious to you over time. On off becomes more obvious. Slowness, stiffness, tremor returning.
Oh, I know, but I can tell when it's off, like you're not or not.
And then, I'm just gonna say this is very sexist, but I'll say it. Men are not as old as mine. I don't think so.
It's okay to say it, I don't know that.
And wives are more observant than husbands, most cases, not always, there's exceptions. But, let me tell you something else that could be going on. So. If you have Parkinson's disease, those of you that do in the room, when do you shake the most? When you're what?
Thinking.
Excited, when George is winning that ball game. About to score a touchdown, you start shaking more, right? Or when you're nervous, when you're upset, or when you're distracted. Okay, so if I have a patient with Parkinson's disease that comes in the office and I have them say, all right, close your eye, what are you into? I like gardening and flowers. Okay, tell me as many flowers you can. Petunia, tulip. The more they start talking about their tulips and petunias, they start shaking more, because commonly you're trying to grab your hand and suppress it and reduce the tremor, right? That kind of thing. And you'll see tremor come out more with distraction or other things like that. The other thing that happens is with exercise is enhanced physiological tremor. When I was a kid, I was in 6th grade, I could lift over my head almost 100 pounds. And I would lift weights. Don't look it now, right? But so I would lift weights when I was a kid. And I noticed that after I lifted weights, golly, my muscles feel shaky, or when I hold something, I feel shaky. That's called enhanced physiological tremor. That could also be going on with your husband with rock steady boxing, that his tremor is enhanced because he's been exercising on top of his Parkinson's. And then it gets better later. Yeah.
We have an online question.
Sure.
Is there a correlation between lower testosterone and PD?
There sure is. So there's a guy of Parkinson's named, that's a friend of mine, good friend of mine named Michael Oken. Michael Oken is at the University of Florida. And he showed in a paper that was published in the Archive of Neurology years ago that testosterone levels are reduced in Parkinson's disease. And he didn't show tremendous benefit of testosterone supplementation, but it appeared to help symptoms some. So that could be worked out with your primary doctor, whether you someone you're low T or not. Yeah. Low spin one, high T.
All right, with COVID increasing, and is there any special treatment if you were to get it with Parkinson's that you should have? Because I know for my husband, when he got it, he ended up 20 days in the hospital and his liver was shutting down, after taking all the COVID drugs. So there should have been something. I tried to get the antibodies, but you had to take, what's the P one? Paxlovid first,
Paxlovid, yeah.
within 48 hours, but for 5 days.
Yeah, that's
And
not
then
fun.
get it didn't make any sense that you need to get the antibodies within 48 hours, but you had to take that for 5 days first. But it really affected him.
Yeah, so I would say if you're an early Parkinson's patient, you probably do as well as anyone else. If you're a moderate to down the road Parkinson's patient, you're certainly more risk of having more side effects or problems with it. Especially if you have comorbidities, high blood pressure, diabetes, breathing problems, heart failure, anything like that.
None of those, just
Any of that can predispose. But yeah, I don't know of an algorithm that's specific for Parkinson's disease for COVID-19 treatment of how to do it. But yeah, getting more aggressive therapy sooner would be the wisest thing to push for.
And then on the Keppra that you mentioned, what is the level that should be taken then to help you?
Procedures.
Well, I thought you said it helped with Parkinson's.
No, the company UCB makes Keppra. You've probably heard of that drug.
Oh, yeah.
That's the most prescribed antiepileptic in the world. And Keppra is just one of the drugs they make. But they make a small molecule inhibitor called UCB 0599, I think it is, that we're studying in a clinical trial.
Okay.
Yeah. Different drugs.
Okay.
Yeah, Joe. Oh, no, it's fine.
We don't know if the dopamine brain are core issues for Parkinson's. But we also know that it continues down our body, continues down the arms and legs, That's, so there's a theory, sort of gut theory. That you talk about.
About how the gut's involved. So Amal Sharma at MCG, has he spoken to your group before? Y'all need to invite him. Invite him, AMOL Sharma, SHARMA. So he's done research in Parkinson's disease in the gut with us and his own research, along with Dr. Satish Rao. Dr. Rao's RAO is one of the world famous gut motility experts. So gut and Parkinson's. The gut doesn't move normally in Parkinson's disease, and it has two major dysfunctions. One is from mouth to anus. The gut does not have typical classic peristalsis of moving food through. Hence, you can get backed up and have constipation issues. Also, when you go to poop, normally when we poop, our anus relaxes and lets stool pass. Our belly contracts to push stool out. And then other muscles of our pelvis and bottom relax and contract to help the stool pass. But a lot of folks with Parkinson's have dyssynergia of that, where the contraction and the relaxation is out of whack. So gut can be affected from two different mechanisms for Parkinson's disease. Kathleen Shannon at Rush showed in a paper that Lewy bodies are present in the gut preceding Parkinson's disease diagnosis in patients. Okay. So there may be a link between the environment, right, well water and pesticides and things that we get from our environment that influences the process of pumping alpha-synuclein in the nerve cells of the gut first. Okay. So one of the first places that Parkinson's begins, according to the Brock theory, Heiko Brock, a pathologist with a lot of brains, is the dorsal motor nucleus of the vagus nerve. The dorsal motor nucleus of the vagus nerve is in your medulla oblongata. You ever heard of the medulla oblongata? I bet you have. That's your brainstem, okay? And that nerve, what does it innervate? It innervates your gut, and it helps with gut motility, okay? And so the process, we think, starts there. It may start from the gut and spread centrally from the gut nerves into the nervous system that way, and then come up to the brainstem, up to the midbrain where the substantia nigra is, and then affect the rest of the cortex over time. Okay, so that's one of the theories about the gut being involved. There's also issues, and it's a very hot topic, by the way. COVID is published every second about causing this and causing that, and you're going to get Parkinson's, and we're all going to get Parkinson's, and we're all going to die of Alzheimer's and Parkinson's. Pardon me, it's all BS. You got to let all of this stuff sift out and get down to the real nitty gritty. People are publishing stuff because it's hot and they can get grants on it and stuff like that, supporting their theories and hypotheses. It takes time to have all this sorted out, and I bet it's all overblown. The effects of COVID are real. It kills people. Let me tell you about that too. At MCG, whenever COVID was at its peak, the number of people that were in the hospital with COVID that had immunizations was 5. The number of people that were in the hospital that did not have immunizations, that were on the ventilator, et cetera, was 95 to 100 of the 105 patients. So that I can say for a fact. You may grow a third arm later, but you definitely will have less chance of being hospitalized with COVID symptoms with immunizations. So that's one thing I'd say about that. The other thing is, gosh, I'm blanking on the word. The bugs in your gut. What is the word for that? I'm blanking.
Microbiome?
Microbiome, yeah, the gut microbiome, yeah, I guess that's what I'm looking for. So the gut microbiome is affected in tons of diseases, Parkinson's included. It's different. And that may be due to just dysmotility. I don't know. But lots of different diseases cause changes in your gut microbiome. And getting that more normal is thought to be helpful. So, yeah. Yes, Pam.
two quick things. Number one, you mentioned about protein interfering with the absorption of drugs. I know a lot of people will take their scrambled eggs and bacon and their medicine. That's not a good thing to do, correct? I mean,
If you're a fluctuator, so if you're an early patient that is just starting levodopa, the average Joe can take it right off at the beginning and do fine, because a little bit goes a long way. But the person who has on-off effects and doesn't turn on that well, yes, that protein load, because it breaks down into amino acids, competes for levodopa absorption from the gut.
And the second part of that is, I know you talked about the research studies that you're doing. I don't know if you have any currently, but if you could let people know who to contact if they want to become on a list for research studies.
I've got a couple of easy ones that you can do. Anyone with Parkinsonism, you don't even have to have Parkinson's disease, you have to have Parkinsonism. So, which means you could have PSP, you could have multiple system atrophy, you could have Parkinson's, dementia with Lewy bodies, etc. So there's I got some brochures over there, a study called Topaz. Have you heard of Topaz before? Has anyone done Topaz in the room? How easy was it for you?
Easiest to do.
Describe it.
If I can remember, it was such a small thing to do.
So it was zoledronic acid versus placebo, which is salt water, and you had a one-time infusion in your home.
Came and did the infusion, it was not at all intrusive, it was a very simple process. And I just send them a report every 6 months, I think it was.
And you get a little cash for it too, right?
You look cash at it.
Okay.
It's a very simple study, they're just trying to, I understand, they're just trying to determine what the odds are you're gonna end up with bad bones. If this is gonna help you avoid hurting yourself when you fall.
That's the ballpark.
All they asked me is have I fallen, and if I fallen, was I hurt?
Simple question. We don't know this for sure. Whether you have or do not have osteoporosis, does a one-time infusion of zoledronic acid, which is already on the market and approved for bone health, if you get a one-time infusion of that versus salt water, the placebo, and we study you over 5 years, which group does better with falls, breaking a hip, or any of that kind of stuff, or mortality, morbidity? Asking that question, who does better, the infused group or the placebo group over time? And then you answer the questionnaires, and you get paid a little bit to do each step. So would love for any of you to pick up a card and consider that. It's easy to do, all that's done in your home, and it's not too intensive. The other study is called Generation, I believe, PD, which looks at first genetic mutations. They're doing genetic research. Who knows the two most common genetic mutations in Parkinson's disease? I asked this last time I talked, y'all should know. Over there. LARC2? GBA. Okay. Glucose cerebrosidase is an enzyme that we all have in our bodies. And then LARC2 is leucine rich repeat kinase 2. LARC2 is a mutation that a certain person has that's very rich, and you use his software product every day. What is that? Google. Who's the co-founder of Google? Sergey Brin. Sergey Brin has the LARC2 mutation. Okay, there's some other people that have LARC2 mutation too. But those are the two most common genetic mutations that occur in clinical practice in the States. It's less than 10% of people have a single gene causing Parkinsonism, and most of it's sporadic or a combination of genes that predispose you to developing things, plus your environment. How many of you drank well water growing up or grew up on a farm or a rural area? No one?
From Michigan, it's all well water.
All the water, okay, gotcha, yeah. So that's a higher risk environment, we think, because the pesticides may seep into the water supply somewhat. So herbicides, pesticides may be linked to local Parkinson's disease. Yeah. It's on the card there that I can give you. It's over there in the chair. And you go to a website, and then they'll contact you and discuss things with you and get your consent and go from there. Yeah, very easy to do.
We have a follow-up online question. Is there any way to safely increase testosterone, even combining these two, vibration and testosterone?
Vibration.
Yeah.
I didn't know that vibration increased testosterone. Let's see.
I just read the questions.
Okay. I don't know of a clear, safe way. I would say I defer to your primary care doctor or your androgenologist, if you have one of those, about testosterone things, because having too much of that kind of stuff can be detrimental too. Like, let's say you had some prostate cancer brewing. If you increase your testosterone in that situation, it could feed the prostate cancer and not be a pretty picture. So make sure you're okay to take testosterone supplements, etc. Yes.
Come across a lot of people who are believing in red light therapy. Can you explain what the red light therapy, the idea of putting a red light on your head and having it affect Parkinson's?
Oh, I thought you were talking about the trip to Amsterdam.
You don't think people are looking from Australia?
So, but no, red light therapy, I don't know a whole lot about it, but I'll say this. It's been used before for neuropathy, infrared kind of treatment of the legs for neuropathy symptoms. And some patients have felt that it's been helpful for neuropathy symptoms. Is this infrared therapy that goes inside the skull, kind of shines a light inside the skull kind of thing?
Actually, it's just a hat.
A hat?
They put a little hat on their head that flashes red lights. A better question would be this: there are so many people out there trying to get so much money from us. What do you look? What should we look for when we start seeing those things? Everybody's got their herbs, and everybody's got their red lights, and there are all these crazy things. What's the eat? There's some simple things we should follow, other than the fact that we should just listen to our doctor.
I'm a doctor and I don't know everything. That's for sure. When you come to support groups, you learn from buddies and friends that have gone through things that your doctor didn't tell you about, and they give you pointers and help you. So I'm not saying that I know everything, but there is a lot of quackery out there. And I gave a talk once for the support group on quackery. So when you're Dr. Perlmutter and you're down in Florida and you're charging $2,000 a pop for glutathione infusions, and it doesn't really cross the blood-brain barrier, that may be quackery. When you, without proven data that it works, when you give someone a jellyfish protein, Prevagen, and you have lots of claims that it does this, this, and this, and it's all anecdotal evidence without any science behind it, that may be quackery. So what I said to my colleagues at school was, I said, whenever I'm done doctoring, I'm going to sell out. I'm going to make a supplement. And I'm going to go online and say, Dr. John Morgan endorses this. You know, there's relaxing for sleep on Fox. There's all these kind of different things. And these things may work. I'm not saying they may not work, but you need to have some data behind it before you believe it. But placebo is a strong thing. Placebo works miracles sometimes in Parkinson's trials. It's actually a hindrance in Parkinson's trials. Why is it a hindrance? Do you know? It increases dopamine when you take placebo. So if you increase dopamine taking placebo because you think you're better, it's kind of hard to overcome the placebo effect. And placebo effects can last 16, 24 weeks in Parkinson's. It's long-term effects sometimes. So, but if it sounds, the old adage, if it sounds too good to be true, it probably is. And I think that's a really wise statement whoever said that originally.
What is the timeline / rate of progression for PD? Another online question.
What is, how about this? Can you ask them, what is their end target point? Where are they looking? Where are they looking to get to? Yes.
I just have a question. I would like to know how long it will take for you to write a prescription for cannabis, medical cannabis.
Probably a long time. I haven't written it because I don't have the approval to write it, that kind of thing. It's gonna be legalized in all 50 states soon and easier to get for everybody. If reefer helps any patient in any way, and I'm fine with it, it doesn't bother me. I prefer them to eat it rather than smoke it. Because one marijuana cigarette is equal to 10 cigarettes. Carcinogen potential, I was told that years ago, right?
Yeah.
That's what they say. But, yeah, you have to have a special permission, and licensure kind of to write that kind of thing, but it'll be legalized soon, and I don't have any trouble with anyone using marijuana, in my opinion. Getting to Georgia, yeah, it'll come. Yeah. Did you get an answer?
No, not yet. No answer yet.
Okay. So I'll briefly answer what progression is. Individual. Okay, so it's hard to say. Some folks progress fast and relatively rapid. Some folks live a very long time with the most benign Parkinson's disease that you can imagine, where they're rolling great forever. And then all of a sudden, something changes, they hallucinate, they have memory troubles come in. What gets most folks in the end is half die of other things, of cancer, heart attack, stroke, pick your poison, stuff that kills us all. Half die of complications related to Parkinson's disease. And that's from falling and breaking a hip and not recovering well from that. Or dementia and psychosis, hallucinations, and being in a nursing home and not doing so well from there. So it just depends on the person. But hopefully that's not your fate or anyone else's fate. Hopefully you die how you want to die. The best health.
So this next one, following caregivers. Step one, functions.
And do caregivers extend the life of Parkinson's patient? Gosh, I should know the answer to it, but I don't. I imagine, I don't mean to be smug, but I imagine caregiving shortens lifespan for folks too, on the opposite end, right? Because it's stressful, and it's hard to caregive for a patient. I'm positive it has a positive correlation that caregivers extend the lifespan of Parkinson's patients. Yeah. Yes, ma'am.
She mentioned scrambled eggs and bacon and not taking the medicine. Is there any other hints you can give of when's the best time to take? Or to go to a, I call it seminary.
Oh, roll with it. Lots of different names for it. So if you have on-off effects, or you never turn on, then maybe the protein in the diet may be interfering with the absorption of levodopa. So if it doesn't kick in, that could be either gut motility issues, because we get down to the small intestine, or it could be that the amino acids in the gut are competing for absorption. But the best thing to do is try to work it around meals if you can. If you can take it 30 to 45 minutes before you eat and get it in then, if you don't have much nausea with it, that's a good time, okay? And then a few hours after, if you can do that. But don't sweat it. I'd rather you just get it in versus not get it in.
Because I was told to take it time, try to take it at the same time.
Let's say you don't want to be too far apart. So when your doctor prescribes 3 times a day levodopa, if you take it 8 hours apart, remember half the drug is gone in 90 minutes, right? So you're spending a ton of time before your next dose gets in your system. So you want to take it about every 4 hours apart during the waking day, 8, 12, 4. That's the kind of time you want to look for. Yes, sir.
Important is cognitive exercise relative to physical exercise.
I think it's key. I don't have data to back that up, but cognitive exercise, socialization, what you do in the support group, hanging out with friends, and getting support, all that is so key for your health. Gives you hope, positivity, that kind of thing. We do know that folks who use their brains in novel ways and who do cognitive exercises have juicier, bigger brains, less shrinking of their brain. We all start out with a grape up there. As we age, it goes to a raisin. If you have memory troubles, you go to a raisin faster than your peers. Okay. And the use of cognitive exercise, of reading a new book club, Sudoku, crossword puzzles, watching a movie, but not only watching that movie, discussing, well, what did you think, Bob, about that plot that happened? And what do you think happened to her in the long run? Or those kind of questions like that. Talk about what you learned to see that you process it, remember it, and those kind of things. So cognitive exercise is very important. I firmly believe in that. Yes.
What Parkinson's drug affects sleep?
What kind of
What Parkinson's drug affects sleep?
affects sleep? That could be any of them. Okay, so classically, dopamine agonists can make you sleepy as they kick in. Levodopa can make you sleepy as it kicks in. Patients with Parkinson's just in general have screwed up sleep. So REM behavior disorder, imagine you're off in the bed at night, you can't move, you can't turn over, you can't adjust the bed sheets very well, and you lay there, oh God, I can't get comfortable. Or you're going to bed and your tremors bothering you, or you get up and pee and your tremors bothering you, or you get in bed and you're dyskinetic and you're writhing and twisting. Then you reach over and meet the mess out your loved one because you have REM behavior disorder, you're fighting off a bad guy. And you wake up, you know, and they say, hey, what the heck are you doing to me? And that wakes you up. You have to get up and pee because you got an old man prostate and you're pee 3 or 4 times a night. There's so many things that interfere with sleep as we age that make it more difficult. Drugs included. Stimulants, of course, if you take a stimulant to stay more awake during the day, some people take that occasionally, like Ritalin or Adderall, things like that, or their Parkinson's not very often. You take that earlier in the day, those kind of things. And then sometimes you can be melatonin is helpful for sleep. Taking 10 milligrams at a time with that. Sometimes in earlier patients or folks that are a little more virile, clonazepam can help with sleep and reducing REM behavior disorder, that kind of thing. Trazodone is a classic drug we use for sleep. Benadryl or Tylenol PM, which has Benadryl in it. Those medications can sometimes cause confusion because they're anticholinergic medications. So you have to be careful of those. Yes, ma'am.
Are you seeing more diagnosis of Parkinson's today compared to 10, 15 years ago?
Yes, because my chairman wants me to see more patients. It's tough. So no, it's just the volume. We're always every year. When I started out, I was like 4 patients a half day, and spending 15 hours with each patient, you know, and everybody loved me. Now, like, Dr. Morgan, you don't have enough time for us anymore. You're so busy, and this is your practice goes on. You get fuller and fuller, that kind of thing. So, but in the sense of has the epidemiology increased? Did you see the report that came out the other day? So they think there's been an underestimate of how prevalent Parkinson's is, or what the incidence. So prevalence is how much is occurring at one point in time. Incidence is how much occurs over a given period of time. Okay. So they used to think that there was 60,000 new diagnoses per year. They now came out and revised that major finding that it's 90,000 new diagnoses per year. So they underestimated significantly. There's at least 1 million with Parkinson's in North America, and there's probably 6 million worldwide. There's 5.4 million with Alzheimer's in America, and 20 or 30 million or more. Much more than that worldwide. So, yeah, it's higher than we thought.
Which report are you referring to?
I don't know, but if you type it in, you Google it, just say 90,000 per year prevalence of Parkinson's disease, you'll find a paper. There's a new paper. Yes, ma'am.
If they take their, cinemax at 8, 12, and 4,
Yep.
what do you do when they're shaking is like a vibrator in the bed
At night.
at night?
Yeah, so some patients need to have a fourth dose sometimes, or be on an extended release preparation like Rytari that lasts longer. But yeah, 8, 12, 4, and 8 is a very common 4 times a day regimen. And by the time they go to bed, let's say at 10, they should still be kicking with a little bit of and the system. Some folks even need a 5th dose. You know, Dr. Morgan, I get up at night and go pee, and then I come back to bed and I can't move and I'm slow and I'm shaking. And I'm like, well, take a dose and leave it open on the night. You know, I'm not in the person's body, so I'll let them, I usually give them honorary doctor privileges to change their doses around a little bit. And so tweaking it to what works best is very common.
Because I could spread it out so that he could go to sleep and he does go at 10. But you're saying that's not really good for the day. So we need to-
Yeah, it's,
Doctor will get that.
well, it's all dependent upon what you can work out timing wise to give him the best movement throughout the day and the best movement through the night if he needs to move. Some folks are like rocks. They just lay down in bed, they get a pee once a night and go right back to sleep. You ain't gotta worry about them giving any medicine at night. But some folks have symptoms that bother them significantly during the middle of the night, and I give them solution for that. Yes, ma'am.
What about alcohol, like wine and alcoholic beverages with Parkinson's?
Don't do it. Just kidding. So, drink up. No, a little bit of alcohol is fine. Of course, just don't be a drunkard, because I asked this question of a physical therapy researcher at the University of Florida when I was visiting there. And I said, his name's Chris. I said, Chris, we should do a study in Parkinson's disease. Parkinson's patients fall as the disease progresses, right? There's lots of different reasons for that. Freezing. There's tripping over the bearskin rug, which you shouldn't have there. There's the little dog that crosses in front of you and trips you up. There's you're half asleep and the night light's not on, that kind of thing. You trip over the threshold of the bathroom. 5 main causes, or you freeze. What about drinking? Anybody knows who their Parkinson's when they're half drunk or drunk? That they have more tendency to have balance issues beyond what they used to? I asked them that question. So drinking too much with an imbalanced Parkinson's patient is not the best. Be careful of that. Yeah.
Are there any studies or any work going on with maybe therapeutics with probiotics? We were talking about the gut-brain connection, and I don't know what probiotics might add to the formula.
Yeah, I didn't have a chance. There is some research into that, including the microbiome of the gut. I had a guy contact me from the Boston area that I didn't have a chance to collaborate with much because I was just so busy. But he was looking into the gut brain connection and looking at using probiotics with other researchers and things as well. But yeah, so that's been going on, and I'm sure there's numerous studies going on in that. Yeah. Y'all question now? Well, I want to appreciate you for coming tonight. I hope you learned something. I learned something always from y'all, and I appreciate you having me, and God bless you in your journey.
Thank you.
Thank you, Doctor. I shut this off. So y'all can hear me, right? Okay. Thank you, Dr. Morgan, for joining us tonight, and we have a small token of our appreciation. It's would have been great this weekend, but
Thank you.
yeah.
Appreciate it so much. Thank you.
So thank you all for joining us as well. Thank you everyone on Zoom, Facebook Live. If the group can help with
Desserts.
eat desserts, Pam told me I need to announce that. Eat desserts. I've seen a lot of new faces. Come back and join us. Every meeting is a lot of fun. We just have different speakers. Some we just ask questions of each other. There was a really great question and answer about travel. So, how do you travel with Parkinson's? So always something to enjoy. Also, the camaraderie is something that we all miss since COVID. So, again, if the board or the group can help with anything, let us know. Otherwise, thank y'all for joining us. Oh, yeah, thank you, Penny. You don't have to do that. It's on Facebook Live, right?
Yeah. Yeah, I love the comments on there. There weren't any questions. Sometimes it seems like the comments are like delayed and popping out there, but
Yeah.
I didn't have anything just now.
Hey guys, here are the topaz cards, if you are interested in the research. And then here are